My name is Gill. I'm the Dementia Pathway Lead on the Enhancing Quality and Recovery Programme. First of all, apologies, I'm not Kay Mackay, our Director. She's at a EQ collaborative event that's being held at Gatwick. Des has already mentioned reducing variation, and hopefully this brief overview of our EQ and our programme will demonstrate how we're working towards achieving this. The ethos of EQ&R is around reducing variation and delivering quality standards. And it's very hard to talk and press and not get an echo, so apologies if we get that. Oh, that's not working at all. The vision is trying to find out and establish what variation is going on in day-to-day practice in our acute hospital trusts, mental health trusts and private providers. As Des has already mentioned, it can sometimes depend what day you're admitted for your surgery, who your surgeon is, what community team looks after them, what GP has referred them, what GP are they registered with. And the EQ&R programme's vision is to stamp out random variation, delivering excellence every time for every patient. This is an overview of the EQ&R process, and the first column, which is on the left as you're looking at it, the pathway selection. This is where we look at evidence of gaps within the service and try to establish some high cost value savings that will deliver improvements. We then move on to working with clinicians to the next section, the evidence and measures. And a lot of time is spent working with clinicians to develop our measure set. Again, we look at evidence and we look to see what quality improvements we can make. So we've defined our measures. We're moving now on to sort of clinical data capture and population on that diagram there. So we've identified our measure sets, and then we work to define a tight denominator population, and accurate data recording is undertaken within the organisations who are working against the specific measures. So we have an external partner, Clarity Informatics, and we work with them to develop what we call a data dictionary, and that clearly defines what is included and indeed excluded from any of our measured population. And we can then start collecting the data. And a few slides on, I will show you an example of what some of that data looks like. Data reporting is where the trusts are collecting their data, feeding it into our Clarity Informatics reporting tool, and we then produce our EQ&R dashboards, which are shared amongst all the trusts with the chief executives, medical directors and others. Trusts can also download their own material, their own reports at any time. We ask them to benchmark themselves against their neighbouring trusts, and in our collaborative learning events we always do show the current data for the collaborative event that we're looking at. So today, an orthopaedic event, we'll be looking at our orthopaedic data, and all the trusts can see where they're performing against their partners across the counties. And underlying and wrapping around the whole of this process is of course patient experience. Not quite sure how clear that is, but that demonstrates the partners that we're working with currently across the EQ&R programme. So we've got 10 acute trusts, 7 community trusts, 3 mental health trusts, and currently 5 independent sector providers. And this is across Kent, Surrey and Sussex. Again, not sure quite how much of that detail you can see, but these are the 4 original acute measures. So acute myocardial infarction is the graph on the top left. Top right is heart failure. Bottom left, hips and knees. and bottom right is pneumonia. And it does show that the trend is in the right direction. And the dates at the very bottom go from July 2010, which is when data was first collected for these measures, and I think it goes up to about May 2012 of this year. I've already mentioned collaborative events. That's key and is the overarching theme to the whole ethos of the programme. And that's, as I said, is why Kay can't be here today. We've got a orthopaedic EQR event at Gatwick, 96 people registered, a broad spectrum of clinicians, managers and other people involved in the pathway. The culture of learning and sharing has proved very popular. All the events are highly attended, and where possible we get patients, carers attending as well. One of our clinical leads at Brighton Hospital Trust has quoted this often, and we use it in all of our presentations. Rapid spread of innovation, driven by the belief that we can move faster by working in cooperation than by acting in isolation to each other. And our collaborative working really does highlight that. As I've mentioned previously, all the data that we collect, we do benchmark performance against each other. And this lists the 10 acute trusts and again the 4 initial acute measures and their benchmark positions. And when we show any of these slides at our collaborative events, you know, people really are sort of straining their necks in the back of the room to see how they're comparing to their neighbours. Still early days. For the acute measures, we started data collection in 2010. But as this slide shows, we are now starting to see improvement in outcomes. So the top box where the blue circle is the ammonia pathway, reduction in mortality. So in 2010 it was at 28.7%. For our 2011 data, that's reduced to 25.36. And a bit further down on the chart, the hip and knees pathway, reductions in readmissions, 2010 8%, 2011 7.28%. So it's a start and it's heading in the right direction. We have 2 new clinical pathways. I mean, dementia has already been mentioned, and I'm sure will continue to be mentioned a lot today. Dementia data collection started in September of last year for the 2 measures that we've currently launched, and acute kidney injury, that's in the development stages now. As part of the prospectus that we've put forward for the AHSN, EQ would look to develop 2 new pathways a year, and at the moment COPD is on the table. And as Des already mentioned in his presentation, in anticipation of the AHSN, we are starting to pick up facilitating the delivery of the high impact innovations. In the NHS South of England, the ambition has been set, and this demonstrates a 5-year trajectory. A lot of work obviously needs to be undertaken, and for some of the high impact innovations we're looking at 4- or 5-fold increase. EQR is already supporting this delivery against the IOFM, intraoperative fluid management. We can't yet measure anything against these trajectories, but as part of our collaborative working with EQR, IOFM is going to be holding a collaborative in December. And we've already extended invitation to manufacturers, and one has already agreed to attend. So that's the date if anybody's interested, and the contact details. We've started to collect data for IOFM against the colorectal pathway. Started in December and November of last year, but it was quite patchy. The numbers, as you can see at the moment, are quite small, but as of January this year, we've started to work with all the acute trusts to analyse their data and get more data submitted. And again, apologies if you can't see this too much, and I'm sure if anybody wants these slides circulated afterwards, we can arrange for that. But this is a typical EQR dashboard that we produce on a quarterly basis. So it lists the, in this case, the 10 acute trusts, and for, in this instance, it's colorectal. It measures against the data that has been submitted from January of this year. And as I said earlier, it is quite patchy, but that just gives you a flavour of what our dashboards look like. And again, on the IOFM for gynecology, small numbers, and data is still in its early stages.